Where should a provider start? I think it's important to remember that first measurement performance period for MACRA begins January 1st of 2017. That's just around the corner. You need to educate your organization on MIPS, understand where it came from, and understand what an organization must do in order to succeed in the 4 categories of MIPS. Remember that the penalties for the lowest performers and non-reporting providers will reach 9% by the 2020 performance years, applied to payments in 2022. In order to educate the C-suite, it can be helpful to estimate the top to bottom potential financial impact of MIPS on a year-by-year basis. You can download the SA Ignite MIPS financial calculator to estimate your score in order to understand what your areas of opportunity are. CMS will also be releasing peer benchmarking for specialties and primary care providers before or soon after January 1st, 2017. Quality measure performance data can be compared against those benchmarks. And while calculating your score under MIPS, knowing the baseline data from your peer providers or groups will help you see where you fall and understand areas of strength and opportunity to focus on as you prepare for MACRA. I want to highlight the importance of understanding MIPS, even if you are considering an advanced alternative payment model. There are thresholds that need to be met in order to be exempt from MIPS, and if those aren't met, a partial constrained MIPS adjustment will occur, or the provider or provider group will be subject to full MIPS. Remember that knowledge and preparation for MIPS is an important safety net strategy. Let's imagine that our colleagues have listened to our 6th series, and they understand what is coming, and they're in. They're saying, okay, I get it. I need to get started. Our practice needs to get started. What activities should they be involved with starting now? And what resources? Should they go out and hire a bunch of people or not? Yeah. And so how do practices prepare if they're starting at a pretty basic level right now? Maybe they've been doing some reporting, or they haven't been, whatever. I'm just curious what counsel you would give to our colleagues across the region in regards to what should we be doing?
Go ahead, John. I think putting on the administrator hat, I think we're all cognizant of the challenges we face in the coming years, and declining margins, what's the saying, no margin, no mission, right? So I think investment too soon could certainly jeopardize any of our organizations. But I think a theme within MACRA is the idea of collaboration and partnership. In recent months, I've had many conversations with my skilled nursing facilities, with tertiary hospitals that we affiliate with, and even pharmacists, that I think we can, if we are willing to sort of show our hand, let people know that we're all trying to figure this out, I think we'll realize that our community pharmacists can help to gather data for us and help with collaborative efforts. Our nursing homes now have much greater pressures for star ratings that impact what they do with their patient population. So I think within our community, there's a lot of energy, a lot of resources, and a lot of time that are going into this that go beyond, I think, our traditional sort of siloed approach of, this is my problem and I'll figure it out, and oh, by the way, I don't want you to see my hand because I don't want to know what you're doing. So I don't know if that is relevant, but there's some necessary partnership, collaboration, and I think from that comes a synergy that we all benefit from if we're just willing to have that little bit of vulnerability in the beginning.
Yeah, so I hear you saying start with the resources you currently have available and see what kind of collaborative efforts or opportunities are to leverage those existing resources. I heard a lot about relationships and the team around you, which in order for us to be successful, we have to really approach this as a team-based approach to care. Mike, I don't know if you have some advice.
Yeah, and I was going to echo some of what John had to say. When we look at the rest of the healthcare providers, the rest of the community that surround our patients, these are people that went into healthcare for the same reason we went into healthcare. They desperately want to make a difference in the lives of their patients, and they know that relationships with that patient's primary care physician is very important for them doing their job. And so being able to connect with those various individuals out in the community will go a long ways towards solidifying that team of taking care of patients. Don't look at communications from home health as being one more piece of information that's bombarding you. That these people are likely communicating some very important information, and they're your eyes and ears out into the home of the patient. And so gathering these folks in, making them a formal part of the team, and actually paying attention. I think giving those members, those outside members of the team, your ear is very important in moving forward. So I think that's a wonderful first place to start.
There are some foundational elements to consider as well. Are you participating in meaningful use? If yes, review the stage 2 requirements and use data to improve workflows and quality in preparation for stage 3 in 2017. If you are not participating in meaningful use, it's important to adopt a certified electronic health record and follow the stages of meaningful use. In order to effectively report data in the MIPS environment, an electronic health record will be an imperative. Have you been reporting to PQRS? Take a look at this slide to get a better understanding as to what your path should be based on a yes or no answer. Have you reviewed your 2014 Quality Resource Use Reports, or QRURs? Let's see what your possible course of action is depending on how you answered. A culture of continuous improvement is critical to succeed in the coming years. It will help to review the list of improvement activities under MIPS and select a few to implement in 2017. The improvement activity category is the only category in which you are only required to report 90 consecutive days of activity when reporting for a calendar performance year. In other words, there's some flexibility in implementing and administering these activities even under a full year reporting scenario.
The other first place to start for many of our practices is find out who their patients are. You know, that we all talk about disease registries, and that's another one of those terms that I think for our colleagues goes right over their head. What are we talking about, a disease registry? Well, what we're really talking about is, well, what kind of diseases do you have in your practice? How many hypertensive patients? How many diabetic patients? And oh, by the way, how many of them have come in? How many of their blood pressures are controlled, or how many of their A1C levels are controlled? I mean, this is information that we all have perceptions about how we're practicing, but taking a very objective look at your practices and how you're performing on the things that you would consider important. You know, we can look with a tainted view about what somebody else says is quality, but we all know if we have a hypertensive patient whose blood pressure isn't controlled, that isn't quality in anyone's book. And so getting to know what your population is and what you're doing with them, I think is
sometimes I think this whole population health thing has been, and people overthink it.
Yeah.
When I look back when I was in practice, it was as simple as saying, hey, I'm going to pull 100 patient charts that have diabetes. And we did that, paper charts, and manually reviewed that to get some sense of how well we're doing on a population. So that was really sort of rudimentary population health management. It's like first you have to have data, and that's where I would say is, well, what data do you have? I'd say to the practice, begin with data. What do you know about your diabetic patients? What do you know about the patients you're seeing? What do you know about access to your clinic? How long do people have to wait to see you? It doesn't require a sophisticated data set or capability to start to quantify where your gaps and opportunities are around quality and cost. And I would encourage people to start there with what you have. Start small. Don't overthink it. And then, then you really get into some really simple, performance improvement methodology where you've got some data, you sit down with the team, you say, okay, we would really like to go from hemoglobin A1Cs and 60%, try to get up to 70. What could we do to make that happen? And try to think of a process you could put in place.
Sure.
It is the scientific method deployed in your own practice, where you have a hypothesis, you put in an intervention, you test that intervention, you see what the outcome of that was, and you measure the outcome. That's the scientific method at its core, and that's all we're doing when we talk about improving quality. You can do that with paper and pencil and Excel spreadsheet, and you could start there. Now, ultimately you're going to have to be more sophisticated than that, but rather than jump out in front and go buy a software solution that costs hundreds of thousands of dollars and go hire somebody that costs you $50,000 to manage this, you don't need to begin there. You can have that on your long range view, but if you've done nothing, that's where I would start. And then think about the patient-centered medical home. If I don't have a patient-centered medical home in primary care, that'd be one of the first things that I try to put in place, because all the elements about patient-centered medical home get you moving forward in the right direction.
Absolutely.
You made me think of just one thing about the kind of culture of medicine is we are hardwired to be resistant and reluctant to fail. And what you just described in that scientific process is an iterative approach. And I think that there has to just be this dramatic shift in the way we look at ourselves and go into this, especially with this transitional year. Be willing to fail, be willing to try, be willing to get in there and get your hands dirty in ways such that we learn and we move forward and we evolve. And I think that it's so central. Mm-hmm. Fear of failure is tremendous within healthcare. We get it, but it's time to act, it's time to move.
Trying to get away from, and this speaks to whether it's in the hospital or in the practice, we do sort of have a blame-based culture, right? So you talk about fear of failure, but to me, I would wrap that around a blame-based culture. But where we need to be in the future is a learning-based culture. We're not looking to blame anybody. We understand it's processes that make it difficult for us to do the right thing. So let's fix the process. But before you fix the processes, you have to understand where the failures are. You're not looking to blame anybody, but to say, here's an opportunity for us to all improve. And then you measure the process. And I think the healthy organizations that have made this journey, they're in a learning community. They're no longer in a blame-based community. That will stymie your work. Discuss CMS pick your pace options with your organization and decide which path you will take in 2017 and what your backup option might be. If your practice decides to pursue the full year option, then January 1st is fast approaching as the start date of your performance period. This is a great time to mention the Transforming Clinical Practice Initiative Grant, or TCPI, which is a CMS technical assistance program aimed at preparing providers for success in the quality payment program. The Enhanced Health Network was fortunate to be part of a multi-state coalition that was awarded a TCPI grant. Through participation in TCPI, Enhance is able to provide intensive, individualized technical assistance to our members, which total around 3,100 providers, most of which are in the ambulatory setting and will be affected by MACRA's changes to Medicare Part B reimbursements. The last measure to prepare for MACRA I'd like to talk about is to consider participating in an accountable care organization, or ACO. While this is not a sure win, it's a shared risk and reward dependent on the shared performance of the ACO. The Medicare Shared Savings Program, or MSSP ACO Track 1, is a good example of an ACO, but please note that Track 1 of MSSP is not an eligible advanced alternative payment model. However, Tracks 2 and 3 are. Track 1 will still provide the opportunity to become experienced and comfortable with pay-for-performance operations and challenge providers in reporting quality metrics. However, all providers in the ACO will receive a single MIPS composite performance score that applies to everyone in the group. So, approach these arrangements with care and understand the risk and reward of group participation. Finally, I'd like to emphasize the importance of learning communities and staying up to date with colleagues to learn best practices and adopt meaningful changes to help you succeed in the value-based future of healthcare. This concludes our video sessions on the nuts and bolts of MACRA, MIPS, and APMs. We hope that you found these sessions informative and valuable. If you have further desire to learn more, we've attached accompanying documents for download to read at your convenience. Please feel free to share these documents with your colleagues and practices. Thanks for viewing, and please reach out to Enhance if you have other questions or need any other direction in order to help best position your practices for success under MACRA.